Assalamu alaikum. Good evening. Thank you for attending our GI webinar. We have three presentations today. Thank you, Dr. Abdulaziz, Dr. Nawal, and Dr. Hani for being with us today. We will start first with Dr. Abdulaziz. He is a gastroenterologist at Awam Hospital. He will give us a lecture about eosinophilic esophagitis for 25 minutes. Then will be followed by Dr. Nawal. He will give us a lecture about abnormal LFTs. Then we will have a 15-minute for a question from the audience. And then we will have a lecture by Dr. Hani. Dr. Hani will talk about paroxysmal nocturnal hemoglobinuria from suspicion to diagnosis. So let's start, and inshallah it will be an educational session. Dr. Abdulaziz, the mic is yours.
Thank you, Dr. Abdullah. Let me share my slide first.
Okay.
Can you see my slide now?
It's obvious, Doctor.
Okay, thank you very much.
Go ahead.
So as Dr. Abdullah said, we're going to speak about eosinophilic esophagitis. Now, a lot of physicians, they ask me why you're going to speak about it. It's a rare entity, rarely we see it. Even as a gastroenterologist, we rarely come across it. The reason is this week is considered as eosinophilic esophagitis awareness week. So I will start from the basic, where I will speak about definition and basic of eosinophilic esophagitis. So the definition of it is it's a chronic immune-mediated inflammatory. It's not an acute, it's a chronic immune-mediated inflammatory disease that lead to esophageal dysfunction, and that's causes by eosinophilic infiltration to the esophageal mucosa. There is multiple factorial causes of this: food trigger, environmental allergen, and we will come across that during my presentation. So eosinophilic esophagitis can affect all age group, with incidence peak in the 3rd and 5th decade in adults. Estimated prevalence 30 to 100 per 100,000 in adults, and around 29 to 40 per 100,000 in peds. Mostly frequently affecting males, with a male to female ratio 3:1. This is the prevalence across, multiple studies which shows study the prevalence of eosinophilic esophagitis. The result varies from a very high in North Sweden study around 400 per 100,000 to as low as 2.3 in the south of Denmark by Delby study. So since 2007, the incidence of prevalence is increasing. Maybe this is related to awareness. More gastroenterologists are keen to go for esophageal biopsies while investigating a patient with dysphagia. So since EOE is relatively new, firstly recognized as in the 70s, and something that's they need to look into it more. And in the beginning of 90s, it was firstly characterized by Atwood and Stroman. So it's now recognized as the first cause of dysphagia in young adult population. And this is published by Maud in 2014. The reason of this recent increase are debated, and while increasing recognition and raise awareness undoubtedly contributed, data are consistent with true increase, and this is published by Dillon in 2015. So as we said, there is a major pathogenic mechanism. It's not clear until now. It's multifactorial, still undefined. Interaction between genetics, intrinsic factors, environmental, and antigenic stimuli. As you can see in the picture, which shows the possibility of different pathogenesis. So what are the risk factor or association eosinophilic esophagitis? So they've noticed that it has a bimodal distribution in age. So in children, the incidence increase and peak at the age of 12, while in adults it peaks at the, as I said before, third and fifth decade. Has been noticed more in males with a 3-to-1 ratio, as I mentioned before. There is a high genetics susceptibility with a high degree of heritability with a strong family clustering. Like monozygous twin exhibit high concordance rate, estimated as we can see here 40%. Also sibling ratio increase at 80-fold increase in risk of developing eosinophilic esophagitis. Also, the studies have looked into the genome that associated with EOE, and they've identified around 5 genetic loci that associated with the disease. So ethnicity and race, it's occur in all ethnic group, but most of the study that's happened in white population. Maybe we are lacking study in other ethnicity, but we can mainly see it. I mean, all the studies have shown it's white, young male. So what are other risk factor and association? So they've noticed that it's really strongly associated with other atopic diseases like asthma, allergic rhinitis, IgE-mediated food allergy, and the rate of coexistence as high as 70%. As I mentioned before, there is a lot of genetic predisposition into it, environmental, host immune response, all together they play a role into developing eosinophilic esophagitis. There is an activation of something called thymic stromal lymphopoietin protein gene. And you can review here the cascade of the genetic predispositions. Again, here you can see in these pictures that the atopic disease, which has been seen with eosinophilic esophagitis, you can see here in the circles, there is associated with asthma, atopic dermatitis, allergic rhinitis, and they've identified the atopic or the genes that increase the high risk of developing EOE. When you have both a gene, the TSLP plus the interleukin-4 and KIF3-4, this will lead to, activation, will lead to developing of eosinophilic esophagitis. Again, we are going to the same environmental factors that looked into the association with eosinophilic esophagitis. They've noticed it as more in those who are birthed by cesarean section, premature delivery, the exposure antibiotic during infancy, lack of breastfeeding, living in a population density, in a lower population density, They've even seen maybe it's associated with seasons, smoking, infection, possibly H. pylori. So environmental factors have played a role into developing eosinophilic esophagitis. Again, this study, this picture showing the different cofactors that come together and lead to developing eosinophilic esophagitis and leads to inflammation and the end fibrosis and dysmotility. The reason why I put this picture is to understand the part of the pathway that lead to developing of EOE. As you know that I mentioned in the before that it's a chronic inflammation. It's go through a different pathway than the allergy pathway, the IgE pathway. They call it a type 2 inflammatory pathway, and that's why when we look later on into the medication, you will know that why medication that works against IgE doesn't work actually. So we look into the causes, associated factors, possible pathogenesis of it. So what are the symptoms? What we have to look into adults or children to suspect eosinophilic esophagitis. So most common in children and adolescents, but adults are affected as well. So manifested in children as feeding difficulties, vomiting, abdominal pain, while mainly in adults, the main complaints is solid food dysphagia, and they have recurrent presentation with food bolus that may require an intervention, an endoscopy or medication intervention. So this slide look also into what we can see on the left side. We can see what are the findings or what are the symptoms we'll see in children, starting from feeding intolerance, vomiting, GERD, food impaction, dysphagia, and even failure to thrive. While in adults, the main complaints will be dysphagia, food impaction, and GERD refractory to medical management. So if we suspect an eosinophilic esophagitis based on these symptoms, based on food bolus, dysphagia in a young adults, that there is no explanation for it, what we should do. So as you see in these slides, the diagnosis is generally based on combination, typical symptoms, specific histology findings on a specimen during an upper endoscopy. So consider diagnosis in patient presenting with food impaction or in those with upper endoscopy finding of unexplained esophageal strictures, narrowing, there's a ring, furrows, exudate, edema, crepe paper-like mucosa, or there is a spontaneous or endoscopic esophageal perforation happen while you are performing an endoscopy. So usually you suspect in the presence of concomitant atopic condition, as I mentioned, when there is a 70% relation between atopia and eosinophilic esophagitis. This is a different endoscopic findings. You're going to see starting from in A, you can see a normal appearance, going to edema, going to something called trichalization in C. You can see an exudate in D. There is a furrows, longitudinal furrows in E, and up to having developing a stricture in picture F. This is again showing a similar picture, but in picture E, you're going to see there is a mucosal tear happen after endoscopy that without an explained mucosal tear. So if you find the typical symptoms, the endoscopic findings, what we should do in this situation. So if you have a high suspicion of EOE, it is advised to take biopsy, at least 6 biopsies from the distal esophagus and proximal esophagus, around like 4 centimeters above the lower esophageal sphincter and 14 centimeter above it. You can take around 6 biopsies. So it's here as recommended, at least 6 biopsies should be obtained, at least 2 different locations, distal and proximal half during endoscopy. This is, you're going to see here the progression of inflammation, fibrosis, and different findings you're going to see in endoscopy or histology, and what therapy you should consider in this situation that I will come across later on. This is what the pathologist will see based on our biopsy findings. You can see here in picture C, multiple eosinophilia. In picture D, you can see here an aggregation of eosinophilic microabscesses. So the diagnosis criteria of EOE. If you have an esophageal symptoms and the biopsy is showing eosinophilia more than 15 in high power field. So this is atypical, this is a definitive EOE. But I have to mention that whenever you suspect an EOE, it is advised not to take biopsy only from esophagus. Please take also biopsy from the stomach and the duodenum. So in order to know that it's not a different entity or a whole gut eosinophilic syndromes. I mean, there is no eosinophil in the duodenum, in the stomach, and it's only isolated in the esophagus. So what are the first line treatment? Actually, there is no first line treatment in this situation. It's up to you, and the discussion happen with your patient after you confirm the diagnosis. Usually, mainly we start with medication, and typically we start with a PPI because it's easy access, available, more tolerable patient, they are familiar with it, and there is a good data supporting that. Also, we can consider a topical swallowed steroids, and this I will discuss later on. So this is about PPI. So overall histological response up to 50%. So you start usually with a BID dose. Still, there is no clear evidence which dose we should give, low, high dose. It's, as I said, safe and available option. But you should do an EGD after 8 weeks and evaluate histology response. And if there is a symptomatic histological response, you can consider decreasing the dose. So to confirm a response in AOE, you have to have a histological response that's showing less than 15 eosinophil in your biopsy. What about topical steroids? Overall histological response up to 65%. There is different forms, fluticasone, beclomethasone. Also, there is the oral viscous budesonide. Previously, they used to do it, mix it with the honey, sucrose, but a lot of patients, they dislike the taste, and they stop taking the oral viscous budesonide because of the taste. They cannot tolerate. It needs a crushing, it needs mixing, it needs a lot of work from the patient. And the studies have shown similar rate response among different forms. There is a new forms of budesonide, they call it Jorveza. 1 milligram. The patient, it's so oral dispersible. The patient can put it in the mouth and it will take around 2 minutes until it dissolves. They have to take it twice a day for 6 weeks, extended up to 12 weeks. So this is how the Gervaisa work. And it, like they achieve histological response similar to other forms of topical steroids. In their study, they've shown some histological response or systemic response up to 80%, but overall, all topical steroids have achieved similar response in all different forms. So there is a specific consideration with the steroid. It should be taken after food, no eating or drinking 30 minutes after that. And you treat the patient for 8 to 12 weeks. And you're going to do a biopsy and confirm that he responded to it. If he responds, you can consider stopping it. But actually, it is very difficult to stop this medication, as the relapse rate after stopping it is up to 90% within 1 year. In patients with fibrostenotic disease, you should continue on maintenance dose. So as a complication of eosinophilic esophagitis, you might find in the end an esophageal sphincter, esophageal stricture that needs endoscopic management. So the endoscopic management in this situation is esophageal dilatation. Might need multiple sessions, and you have to aim until you reach 15 to 18 millimeter. So this is about medication in EOE. What about diet? So there is different type of diet available, diet formulas available, elimination diet, starting from elemental diets, which the results have shown response up to 90% in adults and children. Different elimination diet from 6-food elimination to 1-food elimination diet with variety of response you can see here on the right side. So the 6-food elimination diet, the patient should stop taking cow milk, wheat, eggs, soy, legumes, seafood, and nuts. And these are the component of the 6-food elimination diet that the patient should be strict on it. Now, food elimination diets has advantage and disadvantage. And there is 2 ways of doing it. There is a step-up way, and there is a top-down way. The step-up way is somehow less effective. Sometimes they use it mainly in pediatric symptoms, in pediatric patients. But remember that with each step, with each introduction of a new food, you have to do an endoscopy and confirm that still their eosinophil count is less than 15. So with a step up, you're going to use less endoscopies. With a top down, you start from 6-food elimination diet, and you go down to until you reach the non-allergen diet, and which the patient should stop taking. So imagine that the patient has to do up to 7 endoscopies with the biopsies in a top-down 6-food elimination, and every, for example, 2 to 4 weeks, the patient has to go for endoscopy and biopsy until we know what is the allergen that causing his eosinophilic esophagitis or link to eosinophilic esophagitis. So what's on the horizon? What's new? There is something called cytosponge. So when I talk about my presentation, all presentation about doing an endoscopy and taking biopsy. We can use endoscopy and biopsy in the first diagnosis, but what about using other modalities especially when when you're following up the patient, did he respond or he didn't respond? So the cytosponge is basically a capsule with a thread that the patient should swallow, and then it will expand in the stomach. Then the physician will keep pulling it back to scratch and the mucosa, and then we can send it to histopathology to evaluate for EOE. It's still not approved, but it's coming in the horizon, and hopefully this will make it easier for the patient and for the treating physician and avoiding multiple endoscopies. There is also multiple other monoclonal antibodies in the horizon under investigation. As I said, consider that in the eosinophilic esophagitis is Th2 mediated disease, monoclonal against interleukin-4, interleukin-13, interleukin-5. Has been investigating. One of them is lirenetililyb, which also blocks cyclic 8 blockers to induce eosinophilic apoptosis. And it's promising therapy, still not into clinical practice. Other interleukin-5 also under investigation, mepolizumab, risluzumab in children. Like more than 95% of patients in the treatment group in this situation failed to achieve histological remission, but they had all symptomatic response. 3 other trials evaluated also the efficacy of biologic in these patients. One of them is monoclonal antibody against interleukin-13, and they demonstrate histological endoscopic efficacy in 99 adults with AOE. There's another second study would look into dupilumab, which also all of them are, as I say, are under investigations. So what about the guidelines? What the guidelines recommend in managing a patient with AOE? So I took here, there's different guidelines, but I took here the AGA guidelines, how to manage an EOA. And this is a joint guidelines between the American Gastric Association and the Joint Task Force of Allergy and Immunology. So they recommend giving a PPI over no treatment in patients with symptomatic eosinophilic esophagitis. Also, they recommend typical glucocorticoids over no treatment. So all the recommendation you're going to see here are conditional recommendation, very low evidence or moderate quality evidence, except the topical corticosteroids, which there is a strong recommendation behind it. As I say, also they recommend using a topical glucocorticoids rather than an oral glucocorticosteroids. Also, the GFT suggests using elemental diet over no treatment. Patient, it is very difficult to commence a patient on elemental diet, and even it's difficult when you reintroduce the food to decide which one to introduce. So a lot of physicians, they don't go through the elemental diet pathway. So also using empiric 6-food elimination diet over no treatment, part of the recommendation. In patient with in remission after short use, the AHA recommend continue of topical glucocorticoids over discontinuation of the treatment. As I said, there is a 90% relapses rate when within 1 year after stopping the topical glucocorticoids. Also, they recommend in patients with dysphagia from stricture associated with eosinophilia to go for endoscopic dilatation, and they can do it gradually. What about the monoclonal antibodies? So all these, what I put a slide about them, the AGA, GFT recommend using it, but all of them until now within a context of clinical trial. So anti-interleukin 5 therapy should be only with the context of clinical trial. They recommend this. They have a recommendation against the use of anti-IgE therapy, and this is what I mentioned before, that because of the EUA pathways, the anti-IgE therapy doesn't really work. And also, they suggest using Montelukast, chromalin sodium, immunomodulator, or any anti-TNF only in the context of clinical trial. So all monoclonal antibodies should be only used according to the latest AGA GFT guidelines, only within clinical trials. And hopefully soon, there's a promising data, and it will be hopefully integrated within the guidelines soon. As I show you before, there is up to 90% histological response in some of the monoclonal antibodies therapy. And thank you all.
Thank you very much, Dr. Abdulaziz. Very comprehensive, detailed presentation. For our audience, if you have any question, please post it. We will share it after Dr. Nawal presentation. Dr. Nawal is going to talk about disturbed liver function. Dr. Nawal, welcome.
Thank you very much.
Thank you for joining us.
Thank you.
And the presentation is yours. Go ahead, Dr.
Thank you for your invitation. And today we'll talk about the approach to abnormal liver enzymes. And as we all know that AST, ALT, alkaline phosphatase are the marker of liver injury, and they are not the liver function, and therefore they are called liver chemistry or liver test. The bilirubin, prothrombin-time, INR, albumin are the marker for hepatocyte function, and they are the liver function test. And the aminotransferase ALT and AST are the marker of often used and followed. And ALT, they are reflecting the injury of the hepatocyte or the liver injury. And ALT is the mainly localized enzymes in the liver, and it is the most specific enzymes that it is of a hepatic origin. While AST, it is from the liver, but we can find it also excreted from other organs such as cardiac muscles, skeletal muscles, kidney, and brain. And the alkaline phosphatase is a non-specific protein phosphate, which is markedly expressed in the apical pool of the hepatocyte in the canaliculi. And the alkaline phosphatase could be normally abnormal in growing children below 18 years and also in a pregnant woman from the placenta. Also, the alkaline phosphatase could be found excreted from the bone, intestine, kidney, ovary, and lung. This is the shape of the hexonal hepatocyte, as we know, with the central nuclei round one. And this is the structure of the hepatocyte, where we can see the hexonal shape. And between the two cells, this is the apical pool, where is the canaliculi. And we found here in the canaliculi is the excretion of alkaline phosphatase, and the canaliculi, it is the responsible for bilirubin metabolism and transmission. In the mitochondrial is the concentration of the AST, and in the cytosol is the concentration of ALT. And depend on the mechanism of damage, which is different from each etiology, we find which enzymes is going to be elevated. While the gamma glutamyl transpeptidase, the gamma GT, it's a microsomal enzyme which is widely distributed in the cell membrane and cytosol of the hepatocyte. And gamma GT elevation is not specific for cholestatic liver disease. And cholestasis, however, it is increasing the gamma GT. How? By the accumulation of the bile acid, which solubilize the cell membrane of the hepatocyte. And this will lead to release of the gamma GT in the blood. And the gamma GT also can be elevated in more than 50% of people who are consuming alcohol without having any liver disease, meaning liver biopsy is normal. And the gamma GT also can be excreted by other organs, like having pancreatic disease, myocardial infarction, renal failure, emphysema, diabetes, and also certain medication. Therefore, the gamma GT is not recommended to be used as a screening test for underlying liver disease. So what is the normal AST/ALT level? And normally, what we are using in most of the physician practice in different specialty is the laboratory reference range. And the laboratory reference range actually is different from lab to lab and from country to country. And the laboratory reference range is obtained by the mean of all normal values of healthy individual who have no problem, plus minus 2 standard deviation. And this will incorporate 95% of all the population in the area. And this will lead to 2.5% of the individual in the same area will have a higher values, which is normal for them, higher than the upper limit of normal of the reference population. And also there is the research-based value. The research-based value, which mostly not used in the majority of the specialty field, and it is related to the etiology of the disease or condition. For example, there is a NASH in the clinical research network. They demonstrated that those who have fatty liver disease and liver histology are normal, their normal range is 35 to 79% for male and 31 to 55 international unit per liter for women. And we use, as a hepatologist, the research-based value and when we treat several conditions like fatty liver, like hepatitis B, autoimmune disease, we base our decision and management on the research-based value, not the laboratory reference range. And there is also the local adjusted value, which is from different from country to country and city to a city, where depend on the population ethnicity in that area, the lab value can change. Like in US, the area, if it is more common to have Caucasian, the reference range is different than another area, which is more to harbor Asians and different from the one which is more common to have African American. And there is a linear relationship between ALT and the level of BMI. And there is a Korean study of 1,105 patients who are actually not patients, they are liver donors, and they are healthy individuals. They took the biopsy for them during the donation of the liver for transplant. And they found that the range of ALT in the serum is completely different according to the age, the BMI, and their metabolic factors. And this another study which showed that there is a relationship between increased level of ALT, AST without any identified risk factor, meaning patient does not have any disease, and this associated with increased mortality morbidity. Like we see from Arnott in 1998 published a study that the reference range of AST is 18. If it is greater than that, there is 3 times increased all-cause mortality, and came in 2004 with a reference range ALT less than 20. More than that can lead to relative risk of liver mortality 2.9, 9.5 in men, and 3.8 to 6.6 in women. The same for Rahul in 2009, the reference range of ALT 30 in male, 19 in women. If it is greater than that, this will increase liver-related mortality. So what is the approach steps? So it's like any other condition that we see as physician. To approach abnormal liver enzymes, we need all the classical approach from history, physical examination, laboratory, and imaging. And the history is very important. And usually from the history, you can guess exactly which etiology you are dealing with. And the majority of the patient actually asymptomatic. And if they would have a symptoms which is related to the liver, they could have epigastric or right upper quadrant discomfort or pain. They could have fatigue, maybe itching. There may be a discoloration of the eye and skin as jaundice, or they have lower limb edema or abdominal distension as ascites. And there are important history if you are dealing with acute change in the liver enzymes to look for acute insult, and you have to ask about travel or contact with a traveler, food intake, medication, and herb supply. And also, if you are thinking about chronic condition related to, for example, fatty liver disease, you would have to ask about diabetes, hyperlipidemia, obesity, or weight-related issues. If you're thinking about hemochromatosis, you have to ask about diabetes, skin changes, sex hormonal abnormality, emphysema, chronic lung disease, if you are thinking of alpha-1 deficiency or cystic fibrosis that can affect the liver. And also, if you are thinking about autoimmune hepatitis, you need to ask about arthritis, arthralgia, skin rashes, any connective tissue disease, and also thyroid disease. And also you need to ask every patient who comes with abnormal liver enzymes about alcohol consumption, about high-risk behavior or a blood transfusion that can acquire chronic hepatitis virus, and also migration from high prevalence area for the chronic viral hepatitis. And for all patients, we need to obtain the family history about any liver disease, any hereditary diseases, or any autoimmune disease or cancer. And then we go for the examination. And for examination, you could organize your examination into general condition and stability with vital signs with that. We have signs for decompensated liver function or liver failure, like encephalopathy, ascites, lower limb edema, and also the signs to suggest etiology. The strategy for the approach, it is different from physician to physician, but I can show you one strategy that you could use to help you, because the how to organize the etiology based on the lab you have. So the approach strategy could be based on the pattern of elevated liver enzymes. It is either transaminitis, which is mainly AST/ALT elevation in disproportionate to alkaline phosphatase, or it is cholestatic when alkaline phosphatase is elevated, disproportionate to AST/ALT, or it is mixed that all of them are elevated in the same proportion, or it is hyperbilirubinemia, meaning only bilirubin high, while ALT, AST, alkaline phosphatase are normal. And to help you with that, there is the R ratio, which is the formula, which is very useful to tell you about the pattern using the ALT divided by alkaline phosphatase. It is greater than 5, it will suggest hepatocellular injury, transaminitis. If it is less than 2, it is cholestatic injury, and between 2 to 5, it is a mixed pattern. So what is the approach for transaminitis or the hepatocellular injury? Another approach you can use is the degree of the elevation. And this is what we mainly use in hepatology when we look at the abnormality of liver enzymes and to think about what is likelihood of the etiology. There is a borderline elevation, which is AST/ALT elevation less than 2 times upper limit of normal, mild when they are elevated by 2 to 5 times upper limit of normal, moderate when they are elevated by 5 to 15 times upper limit of normal, severe when it is more than 15 times upper limit of normal, and massive when it is greater than 10,000 times upper limit of normal. And there are several causes for transaminitis or hepatocyte injury, which you can find it everywhere. And I'm sure everyone knows all this, so that I will not be talking about them specifically. We'll just talk about the strategy. So if it is a borderline ALT elevation, this means 2 times upper limit of normal. So the level in your reference lab will be 66 international unit per liter or less. So you obtain the history of the patient, and usually you look for the common etiology which will lead to this borderline elevation. And mainly we are talking about fatty liver. So you obtain a history to suggest risk factor for fatty liver. We're looking for chronic viral hepatitis, which could have the same picture. Any medication which has hepatotoxic effect could have the same range, as well as alcohol consumption. So you will order FBC to look at hemoglobin platelet level, the liver chemistry and liver function, and you order the virology screening for hepatitis B and hepatitis C, also for iron study, because hemochromatosis could have the same borderline abnormality, and abdominal ultrasound. And this is exactly what we said we are looking for. And if all these investigations you've done are negative, then you observe the patient every 3 to 6 months, and you are repeating the liver chemistry. And you be sure at this stage you discontinued all the hepatotoxic medication, and if there is any risk factor, alcohol, you discontinue alcohol as well. And if there is any persistent elevation of these enzymes, you could extend your assessment to obtain assessment for autoimmune hepatitis with ANA, anti-smooth muscle antibody, immunoglobulin. You could screen for Wilson disease using serum ceruloplasmin, and you could screen for alpha-1 antitrypsin deficiency. And if history suggests, you could check also for thyroid disease and celiac sprue. And if all these assessments after 6 months are negative, then you can observe the patient every 3 to 6 months. And at this stage, there is no indication to refer to a hepatologist, and I will show you on another slide how to do it. The fatty liver disease is one of those conditions which lead to borderline elevation of ALT and AST. And the elevation of the enzymes are really not non-specific for fatty liver. It could be ALT elevated, it could be AST, it could be only alkaline phosphatase. This is really non-specific pattern, but often the ALT is higher than AST, and always the range is less than 300. You won't see it greater than 300. And the thing that you need to notice when you are following these patients, that the levels are fluctuating, sometimes up, sometimes down, with no intervention even with the patient. At this stage, as we mentioned, you will do your screening and you do ultrasound of the liver. So you did the ultrasound, which showed increased echogenicity of the liver, suggestive of fatty infiltration. And the ultrasound is a very sensitive tool to pick fatty liver disease. You start the management with diet, less carbohydrate, exercise 5 days a week, 45 minutes, and weight reduction of 10%. And if patient diabetic, you do diabetes control. And if patient is diabetic, you may use the weight reduction medications like liraglutide as internist or diabetologist. And at this stage, once you diagnose patient to have fatty liver, you do liver stiffness assessment with non-invasive test, which I will show you soon. And if this stiffness is suggestive of advanced liver fibrosis, you refer the patient to a hepatologist for further management and follow-up. So what is the non-invasive test to assess the liver fibrosis? Meaning I can tell how much patient have fibrosis without obtaining liver biopsy. And there is our scores which are there. You have APRI score, which is using ALT, AST level and platelet level to know how much fibrosis the patient has. Also the FIB-4 score using AST, ALT, age, platelet level. And there is ultrasound elastography, which you could actually send from your, in every hospital, I believe now they have the ultrasound department, ultrasound elastography to check. And if you have FibroScan, you can go ahead. And these scores, you don't have to memorize. You can use it online with, or in your mobile with the apps for a medical calculator. And we'll show you the demonstration of that in our patient. Case 1 is a 40-year-old woman who's known to be diabetic and hyperlipidemic for over 10 years. And the screening blood work showed elevated liver enzymes, ALT of 55 and AST of 49, which is borderline elevation. While other alkaline phosphatase, bilirubin were normal, as well as platelets and hemoglobin. And hemoglobin A1C 7.1 with fasting blood sugar borderline of 144 or elevated. So you go with the screening, as we mentioned, from the history. She has a risk factor for fatty liver disease and no risk factor for chronic viral hepatitis. However, you have to screen it for every patient. Hepatitis B surface antigen and hepatitis C antibody, both has to be screened for the patient, and they came back negative for her. And you do the abdominal ultrasound, and the abdominal ultrasound showed increased echogenicity of the liver, which is suggestive of fatty liver disease. And in the same time, we order ultrasound elastography, which showed the patient has fibrosis stage 1. And we go with the calculation of the fibrosis stage with the FIB-4 score, which showed 1.32, which is consistent of fibrosis stage 1. And this will be a comment that you will see in the app. And also the APRI score 0.6, which shows no advanced fibrosis. At this stage, you start the management of fatty liver disease, as we mentioned, as you all know, and there is no indication to refer the patient to hepatologist. There is a mild elevation of ALT, which was 2 to 5 times upper limit of normal. This means the level is 66 to 165 international unit per liter. And for that, again, we go with the same process of history examination, and you look in the history for any hepatotoxic medication, alcohol consumption, also risk factor for acquiring chronic viral hepatitis. And when you are doing the lab, it's the same. It is essential for each patient: FBC, liver chemistry, liver function, also the screening for chronic viral hepatitis, the iron study, also the abdominal ultrasound. And be sure that you stop any offensive medication or causing hepatotoxic effect, and the alcohol consumption. And if all these are negative, the viral hepatitis, the iron profile, you check for the autoimmune hepatitis with anti-nuclear antibody, anti-smooth muscle ceruloplasmin for Wilson, alpha-1 antitrypsin, celiac sprue antibodies, and thyroid function. Looking for all the diseases that we talked about, and if all negative, you refer the patient to a hepatologist to obtain a liver biopsy to evaluate. And if the level is from 5 to 15 times upper limit of normal, mean the liver ALT is from 165 to 500 international unit per liter. Again, we go through the same process. And at the suspected etiology at this stage, again, we look for drugs, we look for alcohol consumption. And once the level is above 165, you start, while assessing the patient initially, to look for any signs of acute liver failure. And you send the CBC with liver chemistry, liver function, which is very essential, liver function, INR, along with the liver function test. And you look for any acute viral hepatitis, hepatitis A virus IgM, and we look for hepatitis B acute viral infection. So you send hepatitis B surface antigen, and you send for hepatitis B core antibody IgM. And you send for hepatitis C antibody. And if you would think that there is a high risk behavior that, or blood transfusion or procedure that may increase the risk of having acute hepatitis C virus, even if it is negative, the antibody, you will send the PCR because of the window of 3 months that need to be elevated, the antibodies. And you send for iron study because still this is the range where still hemochromatosis could appear, as well as Wilson disease and essentially autoimmune hepatitis and immunoglobulins and abdominal ultrasound. If all these are, if a patient have any signs of acute liver failure while you assess initially, you send immediately to a hepatologist and you consider liver transplant if there is sign of liver failure, which we are going to talk to you soon. And if all negative, that you had been assessing, this patient will need a liver biopsy if the medical condition is stable. And it is important at this stage when we talk about history, was somebody you are thinking about acute viral hepatitis. For example, if patients give you a history of travel or history of contact with a travel, the screening for acute viral hepatitis, it will not be only this. You would have to have sorry, I did not mention it, but you have to order also hepatitis E antibody or PCR to look for acute hepatitis E. Also, if patient has any history of travel or contact with a traveler, there is more options for other viral hepatitis like dengue fever, and also for CMV or herpes simplex. So all in the context of the history that you could modify which other viral hepatitis you need or viral illness that it can lead to acute hepatitis that you have to be searching for. And this is the second case of a 28-year-old woman who was previously healthy, who presented with jaundice. And her ALT was 363, 5 to 15 times upper limit of normal, moderate elevation with AST of 433, alkaline phosphatase of 387, bilirubin was 15, and her INR 1.1, and albumin of 3, with hemoglobin low at 8.9 and platelet low at 73. At this stage, you would think like because of platelet low, anemic with INR of, total bilirubin of 15, this patient is already cirrhotic. However, we'll not go very aggressive with our conclusions initially, especially she's 28. So we have to do all the workup to be sure that this is we are not missing anything for the patient, because she's young, how much of time she had to develop cirrhosis, which decompensated at this age. So you do the whole workup, as we mentioned, for moderately elevated liver enzymes, and you screen for hepatitis B, hepatitis C, and as well as hepatitis A virus IgM. And if you think there is anything to suggest in the history to investigate for other acute viral illnesses, you have to screen for them as well. And you screen for autoimmune hepatitis, and this came back positive for anti-smooth muscle antibody, and also for anti-nuclear antibody 1 in 1,000 speckled, as well as the IgG was elevated. So always when you check for autoimmune hepatitis, you have to send IgG, and when you look for primary biliary cholangitis, you send IgM. And we had to extend the workup to see why here hemoglobin is low and platelet low as association with autoimmune process. So we had to send for LDH, Coombs test, retic count, ferritin, and all came back positive, suggestive of hemolysis. And this we could see not very common with autoimmune hepatitis, but it is like an event syndrome that we associated syndrome with autoimmune hepatitis. And we did for her a liver ultrasound, which showed patent vasculature, which you need to check at this stage once you have high liver enzymes. And we did for her liver biopsy to complete the workup of autoimmune hepatitis, and it does suggest that the patient has actually autoimmune hepatitis, started on steroid and showed response. For elevation of AST/ALT more than 15,000, mean more than 500, is almost the same. However, you be more aggressive to watch the liver function and exclude any signs of acute liver failure along with the history examination. And you send all the workup as we mentioned in the previous slide. In addition to that, you have to be sure you send ultrasound Doppler of the liver, and you really be sure about the toxic screening of the patient, and you evaluated for paracetamol ingestion, even if it was a remote paracetamol ingestion before 2 weeks, before 3 weeks, you have to know about it. And you keep examining the patient for any signs of acute liver failure. And if all negative, you could not find any etiology to suggest, then you, a patient stable condition, you can perform a liver biopsy. And the other condition, when the patient having massive elevation of ALT/AST, again, it is the same process like the previous, and the main concentration is to look whether the patient has signs of acute liver failure. And the etiology is almost the same like the previous slide, but more aggressive. And again, toxic screening, drugs, herbs, supplements, viral hepatitis. It's not necessarily to be viral hepatitis that we know about A, E, B, and C. We have to look at other viral illnesses that it could be associated at this stage with extensive workup as the previous diseases we mentioned in the previous slide. And if patients manifest any signs of impaired hepatic failure, acute hepatic failure, we have to send the patient for liver transplant center and biopsy only if the condition is allowing. And the acute liver failure is the acute or fulminant liver failure is defined as a rapid development of acute liver injury with severe impairment of the synthetic function of the liver manifested as prolonged prothrombin time, INR, and also hepatic encephalopathy in a patient without obvious or previous liver disease. And it requires immediate evaluation regardless of ALT level, because ALT could be only 500 and patient, you think why he will need to transplant at 500? Yes, we had patients who have 500 range and they had acute liver failure. Liver failure King's College criteria. This is one of the modality that you can use. If you are not sure what you are dealing with, you could use the King's College criteria to help you to evaluate whether this patient needs immediate liver transplant or not. What about cholestasis or elevation of alkaline phosphatase? Again, there is causes that I'm sure all of you know, and it is available everywhere we can have a look at. So alkaline phosphatase, when it is elevated, always you ask yourself, is it alkaline phosphatase alone or is it alkaline phosphatase with AST and ALT? If it is alkaline phosphatase alone while AST, ALT are normal, then you have in your history to look for any medication which has hepatotoxic effect, alcohol consumption, and you have to do gamma GT at this stage. Gamma GT, only the use for gamma GT in our approach is only for this condition. If it is negative, then you have to look for other causes of elevation of alkaline phosphatase out of the liver. But if it is positive, then you proceed with ultrasound of the liver, and also look for the medication that it can offend the patient, and you start searching for primary biliary cholangitis and primary sclerosing cholangitis. And for the primary biliary cholangitis, you send antimitochondrial antibody along with immunoglobulin IgM and ANA. If the alkaline phosphatase, if all these tests are negative and alkaline phosphatase level is more than 2 upper limit of normal and the MRI is normal, then we MRCP of the ruled out PSC, then we go for liver biopsy. If it is negative and alkaline phosphatase between 1 to 2 and all this investigation we did, including the MRCP, are negative, we could still observe the patient. And if ultrasound showed any ductal dilatation suggestive of obstruction, or MRCP showed BSC, then you have your diagnosis to go for ERCP or management of BSC. And if AMA is positive, the patient have primary biliary cholangitis. And if you observe the patient because the level is low, you continue observing, but if it persists or start to worsen, or the AST and LC start to rise, the patient will need a liver biopsy. The other elevation of alkaline phosphatase, if there is elevation of transaminitis. And in this, again, we look for drug medication, herbal supplements, and we do ultrasound of the abdomen. And if there is ductal dilatation, patient goes for ERCP or further evaluation with MRCP. But if there is no ductal evaluation, you rule out primary biliary cholangitis. Also, you do MRCP to rule out primary sclerosing cholangitis. And you have to check the patient if they have sepsis or active infection, which can affect the result of the liver. And again, AMA suggests primary biliary cholangitis, and if it's negative, you do MRCP. And if all negative, you have to do a liver biopsy if it's greater, not improving, or you observe if it is between 1 to 2. A third case is a 33-year-old woman, asymptomatic, previously healthy. On screening blood work, we found to have abnormal liver enzymes, mainly of alkaline phosphatase 226 with ALT of 89, while bilirubin was normal, platelet was normal, hepatitis B and C were negative. We did go through that algorithm, and we did for her the markers. We found that antimitochondrial antibody was positive 1 in 160, and the IgM also high at 3.2. And the ultrasound did not show any dilatation of the duct. So this patient has been labeled to have primary biliary cholangitis and started on the treatment with ursodeoxycholic acid, which showed improvement to normalization. What about elevation of alkaline phosphatase in sepsis or hepatotoxic medication that you often see in your practice? So it is always a mixed pattern with the one which is associated with sepsis. And it is, you treat the sepsis and you expect all the liver pattern or the enzymes to improve. Sometimes it does prolong. If it is prolonged, then you check the medication you are treating the patient with. It can actually prolong the effect of elevation of these enzymes. You think tazocine, meropenem, ceftriaxone, these guys do have effect on the liver enzymes. That's why sometimes it's prolonged, while improvement of the sepsis, still the enzyme is still up before coming down. And if they know, and you will notice during the flow of the patient care that the enzymes start to improve. However, the bilirubin start to be hanging there for some time, sometimes actually increasing for a week before it start to go down. And this is at this stage what you will do when this condition happen. You do ultrasound of the abdomen to rule out any biliary obstruction, also to look for any signs of chronic liver disease or liver cirrhosis. And if that is negative, you don't have to do anything at this stage. You just observe the patient. And remember, if the liver enzymes were normal before the sepsis or the infection, you don't have to do the workup for the liver etiology diseases at this stage. You have to watch and observe the patient, especially if they did not develop any signs of liver failure. And why always the bilirubin lag behind? Again, because it's work in the canaliculi, which is between the cells. And you can see in this microscopic picture, this is hepatocyte, this hepatocyte, this hepatocyte. And between them, this is a very delicate line. And it takes time for this line to recover and then to transmit the bilirubin. That's why the bilirubin takes longer time than the liver enzymes in improvement. What about hyperbilirubinemia? Again, the causes we all know, and you can find them everywhere. So you can divide them into unconjugated and conjugated. The unconjugated, you take the history, and in your mind, you look for any when you take the history, you will have a look at the lab to see if there is, to be sure that AST, ALT, alkaline phosphatase, all are normal. But you have to review the medication of the patient. Some of them can cause hyperbilirubinemia. You be sure the patient does not have hemolysis when it is unconjugated. Also, you have to consider Gilbert syndrome. And in Gilbert syndrome, patient will tell you that when I'm fasting or doing aggressive exercise or dehydrated, I become more jaundiced or taking some medication. If persist elevation, otherwise unexplained condition, then you can, if the history also not supportive of Gilbert syndrome, you can send the genetic testing, which is available in most of the hospitals for Gilbert disease. If persist elevation, otherwise unexplained, and patient is asymptomatic, but there start to be worsening level, then you have to consider what is the problem, and maybe liver biopsy will be helpful, because the condition of Gilbert and other condition, the bilirubin is not steadily elevated. When it is continuously rising, this is another problem, not Gilbert syndrome, because Gilbert is conditional according to the patient condition. For the conjugated, it's the same pathway. And again, you want to be sure all the enzymes are normal, including the alkaline phosphatase, AST, ALT. You review the medication. It could be medication related. And also you look at the patient, whether they are on TBN or they have sepsis. Sometimes sepsis can cause hyperbilirubinemia without elevated liver enzymes. And also you want to be sure the patient is not cirrhotic, and this is part of liver dysfunction. And a lot of the cirrhotic patients, they have normal liver enzymes, but bilirubin up, albumin low, INR up. And also you do ultrasound of the abdomen just for further evaluation of the biliary system. If there is any abnormality in the ductal system, then you evaluate with MRCP, and if it is clear-cut for obstruction, maybe go for ERCP. And if persist elevation, otherwise patient asymptomatic, and you don't do anything, but if continuously worsening or start to have rising enzymes and you don't have any explanation, maybe you consider liver biopsy at that stage. At this, we conclude our talk, and the key point that most common condition in our practice for elevated liver enzymes are fatty liver and viral hepatitis, as well as alcohol. Most of the reported causes of abnormal liver chemistry you could see in your practice with proper assessment. And normal value could be different from individual to individual for ALT and AST. Always screen for herbal and alternative medicine supplements while you are screening for risk factor for liver disease of the patient. And also history is essential during evaluation of the patient, and it often suggests for you what is the etiology of the disease. Thank you very much.
Thank you very much, Dr. Nawal. Very comprehensive talk. Unfortunately, we are running out of time. We still have 3 minutes for questions before we move to Dr. Hani presentation. There is one question for you, Dr. Nawal, from the audience. The question is, how common is Gilbert syndrome in our population?
I don't have the percentage or the prevalence of the disease in our region. However, we see, not uncommonly, we see Gilbert syndrome. I have in my clinic around 12 individuals, they have Gilbert, and I know my colleagues also they have. So having Gilbert is not an uncommon condition to have. I even have Dobbin-Johnson as an adult.
Thank you very much, Doctora. I think we will end our GI session. Thank you very much, Dr. Nawal, for your time. Thank you very much, Dr. Abdulaziz, for your time. We can move to you, Dr. Hani.
Thank you, Dr. Abdullah. I will share my screen. I hope you can see my screen now.
Yeah, we can see it, Doctor.
I'll make it bigger. First, I would like to thank the meeting organizers for giving me the opportunity to talk to you tonight, and also the thanks for the speaker, the chairman, as well as Dr. Abdulaziz and the doctor for the previous speakers for their excellent presentations. So my talk tonight is going to focus on paroxysmal nocturnal hemoglobinuria. I'll try my best to relate it to your to general medicine and GI as well. So why paroxysmal nocturnal hemoglobinuria? To give background, PNH is or paroxysmal nocturnal hemoglobinuria, PNH in short, is a progressive life-threatening disease. It causes multiple comorbidities and even can lead to mortality. It can cause thrombosis and organ damage, and really it can affect the patient quality of life. It is a result of chronic uncontrolled complement activation causing chronic hemolysis. PNH is an acquired disease. It's not genetic. It's an acquired mutation of the big A gene, as we could see, and it really affects the hematopoietic stem cells. So it affects all the blood cell lines, the red cells, white cells, and platelets, because the mutation occurs even in the stem cells, and it can even lead to complete bone marrow failure and aplastic anemia. So historically, the survival, it used to be the prognosis really very poor before we understood the disease and with the advances of treatment. So if you look at in a study done in London in the UK between 1940 and 1970, the majority of patients diagnosed with PNH died within 25 years. 72% of the patients died within 25 years following their diagnosis. So it's really life-threatening condition. And I have seen patients dying before we started using eculizumab over the last 10, 15 years. So what PNH is actually not paroxysmal. It's called paroxysmal nocturnal hemoglobinuria, but it is not paroxysmal. It is chronic. It's characterized by chronic hemolysis with exacerbations, acute paroxysm. It is not only nocturnal. The hemolysis can occur the 24 hours. Patients with PNH may have intermittent hemolytic episodes at any time, and it is not only nocturnal. The hemolysis it's not only hemoglobinuria. So 75% of the patients present without hemoglobinuria. I've seen patients presenting only with mild anemia or thrombocytopenia or pancytopenia. So it's not only hemoglobinuria. So here is the history of PNH. PNH was known for a long time, since the 19th century. It's first recognized in 1882 to 1894. And then later, they discovered the acidified serum lysis test in 1939. This is the oldest test we used to do for PNH. Now we moved on, and I will tell you about how we diagnose it these days. Then later on, it was discovered that it's related to the complement with the discovery of the alternative pathway. And then later on, it was discovered that it can be associated with bone marrow failure and aplastic anemia. And then in 1980s, they discovered the mutation in the GBI gene, as I will show you. And then later on, the identification of the mutation in the big A gene in the 90s. And then the big breakthrough happened in 2000, where they discovered the monoclonal antibody eculizumab, which I will talk about, which really revolutionized the treatment and management of PNH. So here is the epidemiology of PNH. It is rare disease, very rare. So we call it even an orphan or ultra-orphan disease. The incidence of PNH is 1.3 per million, and the prevalence, the 15 years prevalence is 15.9 per million. So it's a really real disease. For example, if you look at a study done in Yorkshire, in UK, and where Yorkshire, because Leeds, the capital of Yorkshire, have got a big PNH center led by Professor Peter Herman, who is one of the big figures in PNH. They found like only 79 patients with PNH among population of 3.7 million. If you look at the demographics of the disease, PNH can be diagnosed at any age. My first patient, I diagnosed her when she was 73 years of age, but she had the symptoms going on for about 10 years. The median age is 33 years, and it can affect children. Recently, in Durham Hospital, we diagnosed a 10-year-old child with PNH presenting with aplastic anemia. He traveled to US now for bone marrow transplant. It can affect men and women equally. And the median survival from the diagnosis 10 to 15 years. And this is before we started using eculizumab, that is without the use of the proper treatment, eculizumab. So the next part of my presentation, I'm going to talk about the role of complement in the pathogenesis of PNH, because this is important. So if you look at the surface of the blood cells, even from the stem cells and red cells, white cells, and platelets, they have an important molecule on the surface of their cell membrane, as you could see here. I will put, just let me put the pointer. So here on the cell membrane, they have an important molecule called GBI anchor carrier. GBI anchor is called glycophosphatidylate inositol, or for short GBI. This GBI anchor, it anchors very important two molecules. One is called CD59, we used to call it Mirel, and the other one is CD55, which is DAF. And now they are called CD55 and CD59. These are important molecules to regulate or to protect the blood cells and the stem cells from activated complement. So the absence of the GBI anchor complement regulator will result in lack of CD55 and CD59, and this will increase sensitivity of the blood cells to complement attack. This is a nice cartoon showing the complement, and when the complement get activated by any condition such as inflammation or pregnancy or surgery, when it is get activated, finally it will form a molecule, an important molecule, which is called membrane attack complex. This is supposed to attack, for example, bacteria, foreign bacteria. So we know that a complement is an important system for immunity, but it creates pores in the cell membranes. So, luckily in normal humans, they have CD55 and CD59, which protects the cells against this molecule from attacking the blood cells. However, what happened in PNH, because of the lack of GBI anchor, these cells lack CD55 and CD59. So the cells left unprotected, and this membrane attack complex will attack the blood cells, such as the red cells, and causing hemolysis. So what happened? Because of the lack of the complement regulated proteins, result in chronic uncontrolled complement activation, and activated complement will attack the cells, leading to chronic hemolysis and nitric oxide depletion. And the nitric oxide depletion, because of the free hemoglobin, the hemolysis is intravascular, then there will be a release of free hemoglobin in the circulation, and this will act as a scavenger for nitric oxide. And I will show you why this is important. So the complement activation lead to formation of the membrane attack complex, leading to hemolysis of the red cells, and then free hemoglobin circulation leading to is act as a scavenger for nitric oxide, which leads to the reduction of the level of nitric oxide in the circulation in the blood. So we know that the lack of nitric oxide will cause vasoconstriction and constriction of the smooth muscles. There will also be activation of the leukocytes, causing release of cytokines, and also activation of the platelets, leading to fibrinogen cleavage and platelet aggregation. And this will result in thrombosis. It is quite a prothrombotic condition. So the hemolysis with the release of free hemoglobin will lead to end organ damage, chronic kidney disease, pulmonary hypertension. The lack of nitric oxide will lead to smooth muscle dystonia, and this will cause abdominal pain, as we could see, and it can cause erectile dysfunction, and also will lead to thrombosis in unusual sites, such as hepatic thrombosis, portal vein thrombosis. I've seen PNH patients presenting with portal hypertension. So the role of chronic hemolysis in PNH. So the factors which affect hemolysis in PNH, three important factors, is the proportion of the peripheral blood cells that are GBI deficient. And this is what we call the clone size, how many cells are GBI deficient. It can range from 10%, a clone size of 10%, one cell among 10. It can go to up to 50% and up to 90% of the patient cells can be GBI deficient. This is what we call the clone size. The other important parameter is the degree of GBI deficiency measured by CD59 expression. This can be done in the lab by tests which I will talk about. It can be none. The cells can have no GBI expression at all, and this is called type 3 cell. This will reduce their lifespan significantly from the normal cell, which is a type 1, which have got normal expression. The normal red cell lifespan is 129 days. The one type 3 can go down to only 17 days. It can be type 2 cell, moderate deficiency, and the lifespan will be about 45 days. And the last parameter is the level of complement activation. The complement can be activated with infection, surgery, and even pregnancy. So the more complement activation, the more the patient hemolysis the patient have. So hemolysis, complement-mediated hemolysis, is really associated with increased mortality in PNH patients. And we can measure the level of the chronic hemolysis by measuring the LDH. This is what we do in the clinic. As a surrogate marker for hemolysis, we can measure the LDH. And in a Korean study, there is an important registry for PNH we usually quote is the Korean registry because they have got a large cohort of PNH patients. And in their cohort, they measure LDH patients and those patients, LDH in their patients, and the level of more than 1.5 upper limit of normal. And they found that patients who have got a higher level of hemolysis by higher LDH have got significantly increased mortality, 16.4% as compared by 3.7% by patients who have having got significant hemolysis. The other important marker is nitric oxide. So it's been found in a study led by the Leeds group by Anita Hill. So what they did, Anita Hill and her group, they measured the free hemoglobin level and the level of nitric oxide consumption. And what they found, there is a correlation, a direct correlation between the level of the free hemoglobin and the level and the reduction in nitric oxide. And this is very important for PNH patients because the low nitric oxide is a vasodilator, smooth muscle relaxant. So the low level of nitric oxide is associated with smooth muscle dystonia, vasoconstriction, smooth muscle constriction, and this will result in, importantly for you, is result in gastrointestinal contraction. For example, it can cause esophageal contraction leading to dysphagia, and I've seen that, and it can cause abdominal pain because of the contraction of the smooth muscles in the small intestine. It also will lead to platelet activation and causing hypercoagulable state, leading to chronic, leading to thrombosis. It also leads to erectile dysfunction. So what about thrombosis? Thrombosis, PNH is a very broad thrombotic condition. If it is left untreated, majority of patients can have thrombosis. And thrombosis is multifactorial. It is not one factor. So for example, activation of complement hemolysis will lead to reduction of nitric oxide and vasoconstriction, can lead to platelet activation. It also leads to leukocyte activation with release of inflammatory cytokines, which is a pro-thrombotic condition, and also the leukocyte decreased expression of plasminogen. And this will impair fibrinolysis, so it will lead to increased risk of thrombosis. So it's multiple factors are likely to contribute to thrombosis rather than one event. And thrombosis is one of the leading causes of death in PNH. It can cause thrombosis in unusual size, sagittal sinus thrombosis, hepatic vein thrombosis, pulmonary portal hypertension. So up to 60 to 43% of patients of PNH can have thrombosis, and it accounts for 40 to 67% of deaths. So, and also high LDH is associated with thrombosis and associated with symptoms in PNH. For example, if you look at patients with high LDH as a surrogate marker for thrombosis, if you look at the symptoms, for example, in abdominal pain, patients who have got high LDH of more than 1.5 upper limit of normal, if you look at their abdominal pain, patients with normal LDH and those with high LDH, by as here shown by the blue bar, they have got significantly high level of abdominal pain, higher incidence of abdominal pain. The same goes for chest pain. For dyspnea, they have patients with high LDH, they have more dyspnea, causing like pulmonary hypertension and hemoglobinuria. So if you want to manage the thrombosis in PNH, important for you to know that anticoagulants are not the only answer, because anticoagulation block a single pathway. And as I showed you, thrombosis is multifactorial. So if you use anticoagulation with warfarin, heparin, or new oral anticoagulants, you will be blocking only one pathway, this pathway, and you will leave all this, and you're not treating the root cause of the problem, which is the chronic hemolysis and the free hemoglobin. So you really need to block the hemolysis by blocking the complement, as we will see later. So chronic kidney disease is also common. 65% of patients of PNH can have chronic kidney disease ranging from CKD stage 1 to 5. And CKD is also one of the leading causes of death. CKD is the cause of death in 8 to 18% of patients with PNH. If you look at a study from the Leeds group adapted from Peter Hillman study, as you could see, overall in their cohort of patients, 64% of their patients, they have a CKD, ranging from 43% they have stage 1 to 2, and 21% even going up to stage 5 CKD. Also, pulmonary hypertension can result from uncontrolled hemolysis because of the recurrent venous thromboembolism, pulmonary embolism, and also because of the lack of nitric oxide causing causing vascular constriction and causing pulmonary hypertension. So 41% of patients with PNH can have pulmonary hypertension. And if you look 6 out of 10 patients with PNH can have evidence of pulmonary hypertension even without thrombosis. So what is the take-home? What is take-home message from the previous slides? PNH is a progressive disease. It is life-threatening disease. It causes thrombosis. It can cause end organ damage, and this all can affect the patient quality of life. The complement system, we know it plays an important role in the innate and adaptive immune response. It is a major soluble component of innate immunity. It plays an important role in the pathogenesis of PNH because PNH results from uncontrolled complement-mediated intravascular hemolysis due to the big A gene mutation, as I showed you, leading to reduction of the complement controlling proteins on the surface of the blood cells, the CD55 and CD59. And the uncontrolled complement activation will lead to the severe consequences of hemolysis, the thrombosis, the chronic kidney disease, the pulmonary hypertension, and this will lead to increased morbidity and mortality in PNH patients. So how we diagnose PNH? To start with, PNH is, because it is a rare disease, there is a lack of awareness, and this lack of awareness really will lead to delay in the diagnosis. I've seen patients like the patient I told you about, my first patient, I've seen, she was delayed for 10 years. And the problem is the clinical symptoms and signs of which raise the suspicion of PNH. You guys, the general medicine doctors, see it commonly among patients. Patients with PNH present with fatigue due to the chronic hemolysis. They present with anemia, dyspnea. They can present to you with CKD, abdominal pain, generally to the gastroenterologist, pulmonary hypertension, to the pulmonologist, erectile dysfunction, to urologist. So really common symptoms. So it can be easily missed. So put it in your differential diagnosis and in the back of your mind as one of the causes of this. So in the Korean registry, hemolysis was clearly associated with mortality. So patients with hemolysis, as evident by LDH of more than 1.5, they have got 4.5 increased risk of mortality compared to the general population. And this is because of thromboembolism, impaired renal function, and cytopenia. And symptomatic factors such as abdominal pain, dyspnea, plus elevated PNH really associated with higher mortality and morbidity among these patients. So early identification is very important. You put this PNH as one of your differential diagnoses in your patients who have got unexplained those symptoms I mentioned in my previous slide. And here, for this is slide from the guidelines to identify, since there is guidelines in UAE developed by the Emirates Society of Hematology, and here is in the guidelines patients identifying patients at risk factors. For example, patients who have got an unexplained hemolysis as evident by high LDH, high reticulocyte count, or low haptoglobin, particularly the Coombs negative hemolytic anemia, patients who have got unexplained hemoglobinuria, patients who have got unexplained renal dysfunction. For us hematologists, patients who have got bone marrow dysfunction, such as aplastic anemia, MDS, or unexplained cytopenia. So for all these patients nowadays, we tend to do PNH screening. And also, importantly for you, is patients who have got unexplained thrombosis, particularly thrombosis in unusual sites, or thrombosis, a patient who have got thrombosis and associated cytopenia, such as thrombocytopenia. And the test we do is called, for PNH, is called high sensitivity flow cytometry. It's done by flow cytometry. So any patients with all these, with hemoglobinuria and lab abnormalities, you can send for the test, or you can refer to hematology to organize the test for BNH, which is done by, as I said, by flow cytometry, which is available in a lot of big centers. They do it by either high sensitivity flow cytometry or another test, more advanced test called FLAIR. This test, just to draw your attention, is available in United Arab Emirates. For example, in Abu Dhabi here, they do it for us in Sheikh Khalifa Medical City. In the flow cytometry lab. In Dubai, they do it in Dubai Hospital. However, there is a private lab called Al Burj Lab. Can do it for the private hospital, and I think I know for a fact that it is done free of charge. You don't need approval by insurance companies, because it's done free of charge, because it is supported by the company itself. Biologics and Alexion used to support it. So if you want to do it from, to send for it from a private hospital, you can contact the company, biologics company, drug representative, who can help you with the logistics. But for us in Tawam Hospital, it's easy because we can send it to Sheikh Khalifa Medical City in Abu Dhabi. So the standard testing for PNH, you perform flow cytometry analysis, or it's done on the peripheral blood. You don't need to do it in a bone marrow. We evaluate the granulocytes and red cells for the GBI expression and the clone size. So the request report provides the clone size for us, and with the they use monoclonal antibodies, and again it's the GBI anchor proteins, which is CD59 and CD59. So they tell you the expression of this, the level of expression of these proteins on the red cells and the white cells on your patient. So the take-home message, the diverse and common symptoms of BNH can lead to delay in diagnosis, because maybe there's lack of awareness. So we need to know about the disease and putting it in the back of your mind as part of your differential diagnosis for the conditions and symptoms I mentioned before. It is important to identify these patients at a high risk of disease. It is necessary to understand the current guidelines. There is guidelines. The test is high sensitivity flow cytometry, as I mentioned, which is available, alhamdulillah, in UAE. And optimal testing and reporting can really make a difference in early detection of BNH, which really can be translated in improvement in the patients, and it will prevent the morbidity and mortality among these patients. Because early diagnosis, you can refer the patient to us so we can start the treatment, which I will mention. So here is the management of PNH for once you refer the patient for us. The initial part is supportive care with blood transfusion, with blood and blood products. If the patient has got thrombocytopenia, we can give them a platelet transfusion. If a patient develops thrombosis, we can give them anticoagulant. But the most important is the complement blockade. You need to block the hemolysis by blocking the complement activation in these patients by using a monoclonal antibody called eculizumab or Solaris. This is one available now in Tawam Hospital. It blocks C5 of complement, but now we moved on because now we have got the long-active version of it, which is called ravulizumab. Solaris, you have to give every 2 weeks. So patients have to come every 2 weeks to the infusion center for the rest of their life to control the complement. Now with the ravulizumab can be given every 8 weeks. It really improves the patient quality of life and make it easier for the patient and for us in the infusion center. If the patient still have got ongoing hemolysis or cytopenia, we can use immunosuppressive therapy with cyclosporine. And if the patient have got bone marrow failure or presenting with complete aplastic anemia, we can refer them for allogeneic stem cell transplant. I have just last 2 slides about the long-acting version of eculizumab, which is ravulizumab. Its commercial name is Ultomiris. Ultomiris is actually the first and the only long-acting complement inhibitor. It provides actually immediate and complete and sustained inhibition and blocking of C5. It is a C5 inhibitor. As I mentioned in the previous slide, it provides inhibition for 8 weeks. It is built on the foundation of Soliris or eculizumab. It is 4 times longer life. Its half-life is 4 times longer. It's studied in many studies, phase 3 studies. It's demonstrated robust and sustained efficacy, and it have got a really good safety profile. I've been using these molecules for over 10 years, and I didn't have any major safety concern. The only thing we need to give the patient vaccination against meningitis before starting the treatment, and maybe the first 2 weeks I give them prophylactic penicillin. But once they receive their vaccination, then I continue the treatment. We didn't have any safety concerns. This is slide showing that Ultomiris is as efficacious as Soliris, and they are both quite efficacious in C5 inhibition, as shown here from the baseline. And the next graph showing Ultomiris is as efficacious in controlling the hemolysis. It is non-inferior to Soliris. Soliris or eculizumab is the first monoclonal antibody we use and we're currently using, but we will be moving now in the near future to Ultomiris because it is have got a longer half-life. I think this is my last slide. I would like to thank you for listening to me, and I will be happy to take any questions.
Thank you very much, Dr. Hani. Very informative talk, and thank you again for all speakers, Dr. Nawal, Abdulaziz, and Dr. Hani, for your precious time on Friday night. We exceeded the time. There is no question from audience for you, Doctor. It was very informative, to be honest. Even myself, I couldn't find a question to ask you. During my experience through internal medicine, as you said, it's very rare disease. I came across one patient with paroxysmal nocturnal hemoglobinuria. So for the audience, we will end the educational session now. A link will be shared for the audience to fill the survey and to get their CME certificates. Thank you, Dr. Nawal. Thank you, Dr. Hani. Thank you, Dr. Abdulaziz. Hope to see you again, inshallah, in other educational sessions.
Thank you very much.
Thank you very much. Thank you for inviting me, and thank you for the audience.